Our study is on the topic analysis of OCT Rnfl and minimum rim width in myopic tilted disc and suspicious cup. Myopia can cause structural changes in eyes which make them more susceptible to axonal loss and can cause glaucomatous changes. And tilted disc can cause alterations in Rnfl peak locations and can cause changes in macular ganglion cell complex distribution. Rnfl thickness assessment is an important tool in evaluation and monitoring of glaucoma. However, in eyes with anatomical and structural variations like myopic tilted disc, it can lead to erroneous results. Spectralis OCT GMP edition has a new objective method of optic nerve head analysis, that is Brooks membrane opening minimum rim width assessment. Minimum rim width is the shortest distance between Brooks membrane opening and internal limiting membrane, which measures NRR perpendicular to the overlying rim tissue. Our aim is to analyze and correlate Rnfl thickness and BMO MRW and to analyze correlate visual field changes. This is a prospective cross-sectional study conducted in a tertiary hospital in 60 eyes with myopic tilted disc and suspicious cup over a period of 1 year. All patients underwent complete ophthalmic evaluations including refraction, optic nerve head evaluation, ovality index assessment, visual field analysis, OCT Rnfl thickness and BMO MRW analysis. Rnfl thickness and BMO MRW measurements were topographically compared at the level of hemidisc. Superior sectors are involved in the superior hemidisc and inferior sectors are included in the inferior hemidisc. A hemidisc is considered abnormal if either or both of two superior or inferior sectors was yellow or red. And if both Rnfl and BMO are normal or both Rnfl and BMO are abnormal, they are considered to have topographical agreement. Otherwise, they are considered to disagree with each other, and those cases underwent post-hoc analysis. Inclusion criteria: age group between 20 to 60 years, best corrected visual acuity more than 6/18, and a refractive error up to -6 diopters without synergy correction up to -3 diopters. Exclusion criteria: any non-case of glaucoma patients, any patients with retinal pathologies, and those who underwent ocular surgeries. Our results: 45% were females, whereas 55% were males. 55% had moderate myopes, whereas 45% had mild myopia. The average Rnfl thickness was higher in the inferior hemidisc. The average BMO MRW was also higher in the inferior hemidisc. Coming to agreement between Rnfl thickness and BMO MRW, out of 120 hemidisc, 106 hemidisc showed agreement, whereas 14.16 only showed disagreement, that is 14 hemidisc showed disagreement. In mild myopia also there was good agreement, 19.7% showed agreement. In moderate myopia also 87.17% showed agreement. Out of 60 eyes, 45 patients had normal visual fields, whereas 15 showed visual field defects not meeting all of Anderson's criteria. The 14 hemidiscs which showed a disagreement underwent post-hoc analysis done by 2 glaucoma consultants, and the number of false positive plus false negative for MRW was higher than that of Rnfl, that is not statistically significant. The causes for disagreement were missed local defects, peripapillary atrophy, and shifting of Rnfl peak. In our study done in myopic tilted disc and suspicious cup, 85.83% agreed, whereas 14.16% disagreed, and the cause for disagreement was missed local defect, shifting of Rnfl peak, and peripapillary atrophy. A similar study done by SUBRU et al. In early glaucoma group, 73.9% agreed, whereas 26.1% showed disagreement, and the causes were borderline significance level, local defects, and aberrant blood vessels. A study done by Robodella et al. In myopic tilted disc showed that BMO had an overall higher specificity than Rnfl. Conclusion: the number of false positive plus false negative for BMO MRW was non-significantly higher than that of Rnfl, and the BMO MRW and Rnfl measures agreed in majority of hemidisc, and they disagreed in only 14.16%. So those cases who show disagreement should be followed up regularly, and we can include GCG analysis also to detect glaucomatous changes in pre-perimetric glaucoma. These are my references. Thank you.
Good presentation. A small comment. Please try to avoid abbreviations, and this BMO, MRW, what you're saying, maybe you have told initially the expansion of it. In between also, you can tell once or twice so that if somebody had missed out in the early slides, they can follow, or who is coming. So because that is a new thing, I have not heard before. Rnfl everybody knows, I think. So that's a general comment. And again, the same question as I asked for the previous speaker. What is the clinical implication of this? How will this benefit the patients? So if you do any study, there should be some benefit to the patients.
Nowadays, it has been told that BMO MRW is a better
Now also
modality.
you can expand and tell.
Okay, Brooks membrane opening minimum limit assessment is a better modality, but we did it in myopic tilted disc patients, and we came to a conclusion that in majority it agreed, only in very few cases it disagreed. So there is no need. We can say that we can when there is a disagreement, we should come to a conclusion at our that is after clinical examination, field studies, Rnfl, BMO, everything should be put together, and we should come into a conclusion for how to follow up, manage, and diagnose patients in that cases. Because in our study, BMO is not a better modality as compared to Rnfl. So if at all we can do a better BMO is available, we can go for BMO and Rnfl and compare both, and then come to a conclusion.
Whether glaucoma is coexisting or not is a challenge. Yeah? That is your cohort. In that cohort, already Rnfl thickness itself is an easily discernible value, but we still have doubts whether this is because high myopia. You are bringing in yet another variable which also has the same variability. I'm not sure. Just because you bring that Brooks membrane diameter, I don't think you will suddenly get a clinching diagnosis that this is pakka glaucoma or something like that, unless you have functional corroboration. So this is again a structural looking at the disc with OCT. So probably this, whether it translates heavily on the field is to be seen. I don't think people will adapt to yet another variable, which also is yet another. Yes.